So great. I'm really excited to join this. I am a scientist. I'll start up front with I'm a PhD, not an MD. I am a biological scientist. I studied molecular biology, and I have spent 300 days in space. I wanted to talk about telemedicine in space, and this is something usually a little bit different than I talk about the research on ISS because we've been doing it for a long time, and it's a very interesting environment with some challenges. So I'll just generally talk about caring for astronauts in space, our history with telemedicine, where we are right now, and where we think we're going to go in the future. So I'll give you a little overview of the space station first, kind of to set the stage of where we're doing this crazy telemedicine, and then talk about our past and present. I want to talk a little bit about space medicine because aerospace medicine is quite different than primary care on Earth, and give you a few case studies and then talk about some of our future challenges. In case there's anybody trying to get CME credit, I put learning objectives here. So we are going to look at the on-orbit capability to present and support telemedicine. Talk about our future challenges, particularly when we're looking at longer duration, very deep space missions. And then also kind of assess the factors that NASA has found that are very useful for a successful telemedicine program. So the environment of the International Space Station is definitely different than your normal clinical setting. We have visiting vehicles coming and going. This is our new Crew Dragon vehicle. I have flown in a Soyuz, but we have Crew Dragon and we'll have Boeing vehicles at some point in the future. We do some really interesting things like spacewalks that vacuum in a suit that has lowered pressure to about a quarter of what you would experience in normal atmosphere pressure. We're doing a lot of science on the space station, and we have to accommodate crews from various size ranges. So today, the International Space Station is our main laboratory. This is where the crews are housed. This is in low Earth orbit. It's about 250 miles above the Earth and has been continuously operational for 20 years. Spaceflight environment is very interesting from a medical perspective. So we are at normal 1 atmosphere pressure, 14.7 psi, unless we do a spacewalk, and then we're going to go down to about 4.2 psi. We are in microgravity, so there is some very, very small amount of gravity, but it's so small it makes a difference for some of the physics experiments, and beyond that, we really feel like we are in free fall with no effects of gravity. The temperature is controlled and adjustable, the humidity is controlled, but the interesting thing is we are in a closed environment. So we're doing lab work, but we are living inside our lab. We are living inside our HVAC machine. We're living inside our life support. So that closed environment presents some unique challenges. And of course, we are, 250 miles above Earth. For a Soyuz crew member who launches and lands to Kazakhstan, if they had a critical emergency, we would deorbit the Soyuz, undock from space station and deorbit, and get them to supportive care in Kazakhstan as quickly as we could. But this could be up to 24 hours, and very similar with a SpaceX undocking, except for that we are landing closer to the United States, and so don't have to worry about the international care aspect. So how the human body reacts to microgravity is one of the reasons that we're up there and we're studying this. As astronauts, we are both the experimenters and the experimentees. We are the guinea pigs in experiments sometimes. And there's really a huge amount of flux in that first day and week after we get to microgravity. This is a time of profound change. The body barely knows what to do. It's all been put in an environment that is not adapted to. And it's actually quite surprising how quickly we can adapt to microgravity. But certainly the neurovestibular system is very out of whack. There's something called space motion sickness, which is nausea and vertigo. Most astronauts do have this. We control it with medication and countermeasures. We have a massive change in the fluids and the electrolytes, and I'll talk about that shift later. We have changes in the cardiovascular system. This is sort of a guess at what those are doing, but we may have some more persistent changes in that system where these are some new discoveries, and I'll talk about that a little later. We have changes in our both our red blood cell mass as well as our plasma volume. And we do have white cell changes and some very interesting degranulation that happens around these launch and landing events. We have kind of continuous effects on bone and calcium metabolism due to the offloading. Because we are in microgravity, we have ways to address that and countermeasures. And we have changes in the lean body mass. One thing that is really cumulative throughout the entire mission is the effects of radiation. In low Earth orbit, we don't have as much radiation as we'll be exposed to in the future because we're still in the Earth's magnetosphere. So we have some protection from that radiation. But as we push farther into the solar system, certainly as we go through the Van Allen belts, we are going to have a lot more radiation to deal with and some nasty particles as well. So we categorize all of these things that are happening to the astronauts in our Human Health and Performance Directorate as risks, and we assess all of the risks to the human system. So we're NASA, right? It's a primarily engineering organization. And so we call the human a system that is part of the spacecraft system, as part of the launch and landing system. And we've categorized each of these risks into broad buckets, which are altered gravity. So that's all those physiological changes I was talking about, the balance disorders, fluid shifts, cardiovascular deconditioning, and we'll talk about thrombosis a little bit, muscle atrophy, bone loss, and I will discuss an interesting syndrome that we see in spaceflight. The radiation is its own category that we are tracking because it's got both acute and long-term risks, and we are going to see a pronounced increase in the radiation dose. Our distance from Earth, this really changes things when you can't get to a hospital with an ambulance ride. You know, it's about the same time scale when I was running my lab in Central Congo, and we discussed getting to definitive care and medical emergencies. You're really talking about a 24-hour period before you're going to be able to pull somebody out of the remote interior locations. And then the hostile closed environment. So we think about a lot of things like the vehicle design, how we're scrubbing our atmosphere. CO2 levels are far higher on the space station than they are in any Earth environment. We could have toxic exposures if we have contamination of our food or water system. That's a pretty big issue. There are microbial changes on the spacecraft. This is one thing that I've been studying quite a bit. And we have this decreased immune function as well as changes in your types of immune cells. And then from a behavioral standpoint, you know, everybody talks about the isolation and the confinement. The crews so far have gotten along really well. We train together, we operate together, and we pay attention to the behavioral aspects and have quite a lot of training on this, how to get together and get along as an international crew. But we do know that there's issues with sleep, work, schedule pressure. You know, you're a quarter of an inch away from absolute vacuum that's going to kill you pretty quickly. So you can imagine there is some mental pressures, not to mention that you are in charge of a $100 billion laboratory, which if you do something bad and crash it into the ground, many people are going to be very upset. And I'm making light of this, but there are quite a bit of psychological pressures on the human. Some of our concepts in space medicine are about, you know, we see all these physiological changes, and some of them are just due to adaptation to microgravity. So we tend to think of these disorders like bone loss or muscle loss or neurovestibular as, you know, this kind of illness, a drawback, a problem for the human. And they really aren't for the most part in space. The place where we do see issues are things like cardiovascular and immune. But things like bone loss and you know, our various adaptations that are happening are really because our bodies are getting very good at being in microgravity. So, you know, use it or lose it, we are not using our bone strength, we're not using our muscle mass the way we would on Earth. The human doesn't really need those things in microgravity. The problem is we become very maladapted to 1G, and we want to return our astronauts to this 1G environment. And so that's where these space adaptations can be very detrimental to the human. We also have to think about illness and injury. Because we are so far, we are off the planet. We have mostly professionals in science or engineering and occasionally medical doctors, but not a guaranteed medical doctor in every crew. So this is kind of normal primary care medicine. with probably our highest risks of, accident, illness, injury being along the accident spectrum, getting your hand crushed in a rack, breaking a bone. The transmissible illness is a issue when you have crew launch and landing, but we do quite heavy quarantine. And then any condition that somebody has that's maybe subclinical and is exacerbated by the spaceflight environment certainly could crop up during the mission. And then we also have novel medical findings. We're putting humans in a very different environment. We do a lot of research on them, and this has led to some really interesting observations about human physiology, as well as understanding what we need to do for spaceflight missions in the future. How are we going to help humans adapt to being so far away from the planet, going into deep space, going to Mars, encountering all these incredibly new situations. So telemedicine is really, this is the kind of core pillar of how we approach this medicine in space. We have other supporting things that help us out. So for example, we have a huge volume of requirements, medical requirements for an astronaut to pass before they are allowed to launch. We have ongoing monitoring during the space flight, and we have monitoring and care and rehabilitation when we come home. But if we're just talking about the actual mission, that really is centered around telemedicine. So we assume we will not have a medical doctor on board, but we will have people that are well trained. We do essentially kind of paramedic training so that we can stabilize a patient, do airway support, manage somebody to the point where we can get them to deorbit and come home. We can do IVs and various kind of basic trauma cares that you would expect in a kind of a paramedic ambulance situation. Beyond that, our capabilities really are residing completely on the ground. So we have great communication with the ground. We have nearly continuous coverage. We have audio capabilities. We can privatize these audio loops. We have video capabilities that we can privatize. And we have a team of flight surgeons that staff mission control and that also know the astronauts that are their personal doctor during the entire training phase, which is 2.5 years, really understand the patient history for all astronauts on board. So our video conference availability is dependent on some of the transmission bands, which we don't have complete coverage, but we are getting close to 24/7 coverage. We can do this in Mission Control Houston to set up the audio and the video links, but we've also been able to do this remote, and we use a HIPAA compliant application to allow, if somebody's on call, they can dial into this remote thing as they're getting spooled up to get into mission control for an emergency. We have a suite of medical hardware. The space station is certainly not a hospital, and it's maybe a decently outfitted clinic. We have a lot of issues with flying hardware. It has to be compatible with the space station environment. So it needs to be compatible with the power source. All of the computation needs to interface with the space station computers and not crash them. We have extensive materials testing and certification process to fly any piece of equipment. But we do have some hardware, and we're expanding our hardware right now that we can use in this telemedicine environment. And then training. I mentioned some of the training that we get pre-flight. We do a couple weeks shadowing at Memorial Hermann for trauma and then in the ICU. We can also do what's called just-in-time training. And so we can do simulations of a code on board. As the doctors are watching, we run through this and we practice this a few times in increment. And of course, we've got the remote guidance. So we are not expecting the astronauts to be the people who are providing the diagnosis or the treatment plan. That's all conducted from the ground, but they are a fairly well-informed patient population. So again, a little bit more on the aerospace medicine and the kinds of things that we might see in the telemedicine case from low Earth orbit. The neurovestibular effects are very prominent. It can be almost incapacitating for some crew members. It's a little worse on the way home than it is on the way up. But your first week in space, you are a moderately functional potato and not too much more. So that adaptation is definitely a difficult period. The fluid shifts, which I'll talk about a little bit later are a major issue, and they're definitely a very interesting issue when you think about anything else that could happen to the human in that environment. We'll talk about SANS, the vision changes, and the musculoskeletal, the bone effects. Our kind of standard things that we see in astronauts are just the terrestrial patient complaints you'd see in a pretty healthy, fit kind of crew member population who can't get immediate primary care for 6 months. So headaches, which are a little bit worse based on the CO2 environment, things like rashes because we don't have very good hygiene capabilities. There's no shower on station. Congestion from CO2 and the fluid shifts. Strains and back pains. These are pretty well documented due to the interesting things that happen to the spine in microgravity when it's continuously offloaded. And then things like abdominal pain. Not mentioned on here are UTIs, microbial infections, those kinds of things. So these are all common complaints on the ground. The causes for these are a little bit different. They're usually a microgravity-driven cause. So getting into neurovestibular a little bit more, this is, our overall sense of orientation, our balance and posture, proprioception, how we're going to track as we're moving around, our sense of where our bodies are and how we can move from point A to point B. And then maintaining, we really have visual as the only cue because you no longer have this sense of up and down when you're in space. And definitely the ability to move around the space station if you're feeling extremely nauseous and dizzy can definitely affect your coordination and your smoothness of movement. So we talked about the space adaptation sickness. It's published in the literature. I think it's something like 60 or 70% of astronauts have this. I view this as a truth detector. I think about 100% of astronauts have space adaptation sickness and about 30 or 40 lie about it. So this is a little bit driven by the culture. We have historically had a lot of fighter pilots who view a visit to the flight surgeon as no net benefit, only a drawback. And we have had a lot of emphasis on maintaining landing capabilities in the shuttle days. And so there's a lot of culture that's driving the space shuttle commander and pilot to not fess up to any dizziness or alterations and kind of fight their way through it because their careers could be affected. However, now that we've moved into a little bit more of a long duration environment, we're no longer landing a shuttle on the ground. We have seen people are talking more openly about it. And we do a lot of work to come up with a good medication plan for the astronauts prior to flight so that they have a variety of different countermeasures that they can take prophylactically sometimes, or in the heavy hitter case like Phenergan, when you really see symptoms starting probably at night. And then post-flight is the real difficult one. We can stand and walk, but just barely. So we stagger around like a baby who's learning how to walk. We have great difficulties in figuring out where our trunk is and how to balance that, and proprioception. A lot of disequilibrium and vertigo. Our focus can be impacted, and we certainly have a lot of nausea and vomiting. The good thing about all of this is taking place in an environment where now we do have definitive care. We have flight surgeons available 24/7. We have a medevac type plane that's outfitted to really make sure that we can get the astronauts home safely in a carefully controlled medical environment. But the adaptation as you're going to microgravity puts us clearly in this telemedicine realm where we've talked with our doctors, we have a medication plan, and then we have a lot of calls that are scheduled in that first week between the flight surgeon and the astronaut to kind of address how this space adaptation sickness is going. The fluid shifts are certainly interesting in orbit. So the fluid in space tends to redistribute, and it kind of goes up into your chest and your upper body. And if you think about, we as humans are adapted to walk around on Earth where you've got gravity constantly pulling the blood down into your legs. This is how our cardiovascular system is set up to be pumping this back up. If you then remove all of that force of gravity, the fluid is no longer being pulled down into the legs. It's kind of moving wherever, but we still have this system to pump the fluid up, and that doesn't go away. So the body senses this as the flood around the heart. We start diuresing like crazy, and we settle in within a few days to our new fluid volume, which is greatly reduced plasma volume. So on orbit, we get rid of this fluid. The body functions for the most part okay with less fluid. The heart becomes a little smaller and a little more spherical. Then upon return to the Earth, the gravity is pulling that fluid back down. When we return to Earth, there's not enough fluid to function normally. And this is a very sudden return. So we go from being in microgravity to about 30 minutes later, landing on the planet. And so there's no adaptation period there. So we see a lot of orthostasis. We're starting now to give IVs immediately upon return because we know the crew member is so dehydrated. Whether or not, we don't want to wait until somebody says, hey, I'm really doing bad, I need an IV. We're just starting to push those in, and we see a lot better outcomes with those IVs. So some of the things you can actually see for this fluid loading, this is my very good friend, Kjell Lindgren, who is a flight surgeon and is on orbit right now. He's in space, but you can see this is kind of the ground view. But if you look at him and his crewmates, we essentially get this swelling, we get tissue thickness. It's measurable, it varies between people, but the face gets pronounced markedly rounder, and you have this sensation of head fullness. So some people like it because we call it space Botox. Your wrinkles seem to disappear and you look 25 again, but it can cause a lot of problems for the astronauts in terms of things like congestion, their head feeling full, and all this fluid moving upwards towards the head. One thing that we haven't really researched a lot is what is this doing to CSF, things like glial flushing, all of those processes that are helping clear our brain are affected by fluid movement. And I think that's an important area of study in the future. How do we care for our crew in these environments when these different conditions come up? Our history of telemedicine on the ISS really starts from the beginning of space station. And so you can see this is when we were just putting the first few modules together. We included things like ultrasound in the very beginning of the space program, and we had always had a telemedicine program. This came, in the shuttle days. We moved this paradigm over to spaceflight, and so you can see Peggy Whitson here. By the way, all of these crew members have given consent for these images to be shown. And she's doing training on the ground and then is able to do training to do self-ultrasound with a remote guider on board. And then here are our remote guiders down here. And so we started out with things like voice conferences before we had video capability, video conferences, and then ultrasound was really the first technology that we started implementing and being able to send data back from space. Our current use of telemedicine has greatly expanded. So now we have some more diagnostic equipment on board. We're still heavily depending on ultrasound, but we're starting to do a little bit more with things like test strips for urinalysis. One of the projects that I worked on was to try to get a mini CBC and diff machine up on orbit, which has some challenges in microgravity to make a smear and to get that slide counted. We're starting to do a lot more work now in the area of genomics. So one of the things I worked on my first flight was DNA sequencing capability on board. We've shown that we can sequence both DNA and RNA. We can sequence swabs for looking at environmental contaminants or microbial causes of disease. And we have not put into place any specific genomic testing on board. As these become more and more available on Earth and are used more in routine medicine, we have all of the infrastructure set up. We don't have a CLIA lab up there, but we certainly can do some kinds of diagnostics under a waiver program. Some of the new things that we've implemented have been visual screening, and I'll talk a little bit more about our optical coherence tomography. We started out with a little bit more basic fundoscopy and just images, and we've moved more to very high definition, high resolution images of the eyes and the retina with our SANS concerns. So here is just a little bit of a video so you can kind of see. This is the overhead camera. So we have, when we set up our ultrasound, we have a side camera so that the remote guider can see placement of the ultrasound. and an overhead camera. And they'll have a second crew member assisting, really to be pushing buttons on the ultrasound computer. And the remote guider is then voice guiding the astronaut who's holding the probe and doing their own ultrasound. And so you can see this is kind of our setup with the second crew member helping. We've greatly changed the ultrasound format to make it maybe astronaut proof. So rather than the standard ultrasound keyboard, we've just turned it into colors and numbers. So the remote guider can mention, press pink 2 3 times up, rather than having us have to learn the intricacies of being an ultrasound technician. So here's a little bit more about the eye and the on-orbit ultrasound. I'll let them. So this is one of our very incredible remote guiders. His voice makes me feel like I'm back in space again. And you can see that the communication can happen very quickly. We have not trained the astronauts to be ultrasound technicians on the ground. They get a little bit of pre-flight training where they can demonstrate that they can set up the machine. We use water instead of ultrasound gel, and that they can place the probe in the various anatomical locations that we need to look at. Beyond that, we get very little training on imagery analysis, interpretation, or capture, because we can do all of this with the remote guider. And so we actually can get a really incredible range of images very quickly because of this remote guidance. There is a little bit of a lag because you are talking to space and we have to go through a lot of networks on the ground. And so one of the things that we've had to learn is how to adjust for that lag. So the video lags a few seconds. And so these remote guiders get very good at kind of anticipating, if the probe is sort of going off in the wrong direction, they sort of mentally forecast where that is and are able to give the crew direction to correct that, even though they're on a few second time delay. The other thing is the crew does get quite good at this when they're on orbit. After you do 6 or 7 hours of ultrasound, you start to get very good at finding your optic nerve and various valves in the heart. And so by the end of the mission, the astronauts are actually pretty good at least for themselves, doing all the various scans that we like to see. So a few more specific examples. I've been talking about SANS a lot, and this is Spaceflight Associated Neuroocular System. This has really been discovered in the last few years. And so we started noticing that people were coming back from long duration spaceflight with vision changes that were sometimes permanent. So we instituted a lot more scanning on board. As I said, we were doing the fundoscopy to take pictures of the eyeball. We were doing vision, just these vision checks like you would see at a normal ophthalmologist office, making sure that we're not getting huge swings in whatever correction the astronauts need. And then a lot of work post-flight to determine how the vision has been affected by the space flight. This led us to getting an OCT machine and certifying that for spaceflight. And so then we could actually get those very detailed pictures. What we're seeing is things like swelling around the optic nerve. We're seeing increased choroidal folds. We're seeing optic disc edema. And we picked this up in the fundoscopy, we're seeing these cotton wool spots. And so there are a lot of changes going on. This is quite variable among the astronaut populations. But one of the really interesting telemedicine cases is bringing this new equipment in and then having the remote guiders walk us through OCT, which is a non-trivial setup, to be an OCT technician and to be a good patient. It is complicated by our bandwidth issues. So the OCT scans can take much longer on board than they would on the ground. But we get this incredibly detailed data, and we get a time course of what's happening to the astronauts' eyeballs. We don't have a lot of countermeasures yet. We fly a few drugs that are involved in intracranial pressure on the ground, the kind of treatment solutions we would have there. But this is a lot for diagnosis. And then certainly if we had a case that was absolutely going off the rails, we would bring in the consideration of do we need to demand this crew and bring that person home. We see a lot of these problems resolve when we get back to the ground, but some of those vision changes persist, and we can see permanent changes in people's distance vision because of space. Sometimes the astronauts joke around that this is space LASIK, but we certainly don't want to, have any permanent vision changes. And we don't know if this is cumulative, if as we go to Mars, if being in space for 2.5 years is going to continue these changes. We suspect it may, because we see these changes develop throughout the course of spaceflight. They don't happen immediately in those first 2 weeks and then resolve. So we see this as kind of a cumulative effect. So here are some of the things that I was just talking about. We get these shifts up to 2 diopters. Here's some paper reference if you are very interested in ophthalmology and want to see what's going on with astronauts after long duration spaceflight. This is the optic disc edema. Here you can see this is the OCT image showing this optic disc edema. And here you can see pre-flight and post-flight. And this is not an in-flight image, but you can see immediately post-flight that swelling has continued. Let me go through we see globe flattening. This is the pre-flight shape here in the yellow circle, and then this is our actual in-flight image. And then we also see these choroidal folds, which can be visualized a little bit with a very high resolution fundoscopy and images, but are much better seen in this OCT image. So that is SANS for you. It's an ongoing issue. We've got an active area of research. We're funding a lot of research in this area, but absolutely critical to this understanding of this condition is our ability to see a time course in real time and monitor this condition rather than just look at pre and post-flight images. So SANS has been diagnosed in both males and females. We don't have a great N. We don't fly a lot of astronauts. It seems to be a little bit more prevalent in males, but I don't know that we have a nice robust p-value on that yet. There's no evidence of permanent loss of vision, but some of these changes can be permanent, and most particularly the hyperoptic shifts. The choroidal folds and the globe flattening can become permanent, although those have tended to resolve over time. The edema doesn't spread that far. It's really concentrated on the optic nerve and the disc. But we have established these kinds of guidelines and goalposts where we're seeing this syndrome progress so that we can have specific points that we identify with our telemedicine. And as I said, we think these might be cumulative effects. The severity seems to be related to mission duration. Again, we have a very low N of people that have gone longer than 6 months. The most famous is Scott Kelly, who participated in the twins study with his brother, Mark Kelly. But we are starting to talk about sending people for a year or longer to try to document these long-term physiological changes. And here's kind of the percent of crew. So it's variable. It's not every crew. Not every crew has the same etiology, but we do see this in a large majority of our crew members. So switching gears to why are we getting SANS? There's a lot of different theories out there. It seems to be fairly closely related to increased intracranial pressure. And so one of the things we've been looking at are lumbar punctures. And so to date, we have only done this pre and post flight, but you can see some of the changes that we're seeing here. And so, here's a few of our subjects, and you can see pre and post flight. So post-flight, we only took data in subjects with optic disc edema. We are not seeing huge amounts of peripheral vision changes. And the headaches that we see are really linked to CO2 and environmental factors, not linked to these vision changes in this optic disc edema. As I said, the testing has evolved. We have certified things quickly. We sent up this OCT, and then we sent up a new version of OCT that can take a lot more imagery. We do the standard visual acuity test. I showed you a lot about the ultrasound, and then we have some tonometry capability to look at ocular pressure, but this is, this is kind of this is the device you tap on your eyeballs and get a reading from the membrane. It's variable in terms of the data quality. So for the telemedicine, overall, we train these procedures on the ground for all of the ultrasound and OCT, but we want to minimize crew time. So in the telemedicine space, the time that the patient spends doing these exams is very critical. Our going rate at NASA is $144,000 an hour for astronaut time, and we have a lot of competing priorities to execute the mission. We have engineering, maintenance, scientific payloads. And so we're trying to get this down to be the most efficient process we can. And you saw that with the remote guider. We're able to move through those images and capture them very, very quickly. So this OCT is a wonderful or a terrible machine, depending if you are the subject or the data gatherer. It's really got a wealth of data. We have struggled with the scan length and sort of the burden on the patient. These OCT sessions can take an hour and a half, and we have a low moisture environment on board. We have a lot of dry eye, and so it can be very challenging for the subject to keep their eyeballs moistened. To keep still and steady. We don't have to think about this in gravity. You kind of just put your chin in the chin rest and try to not move your head around. But in microgravity, we're floating all over the place. And so to get yourself positioned at the little work table and get yourself up close up to the OCT machine is a little bit difficult. And then of course, we've got the astronaut assistant that's doing the one that's talking to the remote guider. And then the subject is performing the actual scan. Fundoscopy, we've started to use our OCT machine more for fundoscopy, but this is our older setup. And again, fundoscopy on yourself is challenging. To position the eye cup and to not get light in there can be very difficult, but we have the remote guider helping by video observe the position and then take a look at the quality of the images. And so we actually, one of the kind of unique parts about our telemedicine is that we do have the equivalent of the radiologist or the ophthalmologist that is there in real time looking at the data rather than acquiring the imagery and then sending it out to be read. And so they can say, hey, you've taken a bad picture, try this and take a better one. And so we don't leave the session until we have the data that we need to capture. Here's a little bit more about that ultrasound. And you can see the places that we're really focusing are the optic nerve. We're looking at the blood flow here, globe flattening, and then anything that we can see that's very obvious about the cornea or the lens. So switching into another case study, this is a much more recent one, even than the SANS. This is a case study of venous thrombosis, and this was just published in 2020. And you can see this very unique finding. And I won't go into details because you can look at the New England Journal article. This was not caught through our medical scans. We do a lot of this ultrasound as part of our research. And so we have these payloads that are taking medical type data, but they're really doing it for research. We happen to be ultrasounding in that area, and we happen to catch evidence of a clot, a large one and a very concerning one. And so some of the reaction to this kind of shows you how that telemedicine kind of played out. So here's the kind of the timeline. This patient was launched in the Soyuz. We're doing these various imaging and found that we had this issue. We notified the physician. They immediately started the therapies that we had available on board, but we did not have everything that we would like to have. We are very medication limited on board. We try to come up with the best sort of formulary that we can think of that will address the problems we view as high risk, but we cannot carry an entire pharmacy. We're limited into the size of a few shoe boxes. So we had a vehicle launching to the space station. We were able to get additional anticoagulation medication on board. One of the things that we were very concerned about at this point is if we had another trauma or an emergency undocking due to like fire or depressurization, we now have a patient on blood thinners who's got a high risk of some kind of trauma happening when we deorbit, come through the Earth's atmosphere and smack into the planet. And so we did try to complete the therapy and get the patient stabilized in terms of their coagulation abilities before we came into that Soyuz landing. But we were carrying this risk that if we had to deorbit at any point, we knew that we would have a potential issue with bleeding. So here's the exam after the research and imaging. So we did the research imaging. The research imaging is not necessarily immediately processed. And so when they did find this issue, they then went back and immediately called for a clinical exam to characterize the thrombus. And we then continued this quite extensively once or twice a week to monitor the progression. We identified this during unrelated research activity. NASA does have the nice capability to bring in world experts immediately for these kinds of problems. So we had the capability to upmask the medication, not immediately though. In the microgravity environment, you know, the injections are much more complicated. So we had a lot of telemedicine work here about the treatment. We have to, you know, reconstitute things or be drawing liquids out of a vial with a syringe. There are bubbles. The fluid doesn't go to the bottom of the syringe. It really can be difficult to get a good draw. We also were very unsure how the condition would behave in microgravity, and that led us to do these telemedicine consults with full scans on a highly regular basis. We needed to do this as surveillance. We started with a limited treatment and then made adjustments. The crew wasn't trained for this ultrasound of the large vessels, but we have a skill set and we had been doing remote guidance for ultrasound in various other areas. And we now have, after this, we're very concerned about this. We went back and looked at any imagery that we had, research or medical, where we could see, where we would see some possibility of thrombi. And we did find 4 other cases where we could find evidence of this. So this is not happening in all astronauts, but we are monitoring this very carefully. And then, as I said, the capsule landing, when the parachutes come out, I mean, you feel like Scott Kelly said it very well, you feel like you've been put in a barrel, set on fire, and kicked down Niagara Falls. So this is the acceleration is quite dramatic. And then, of course, we worry about trauma on landing, where we are taking a small ball of metal that's hurled through the molten atmosphere and slamming it into the planet. So this could be it's a car accident. We're very well protected, but we certainly have had lots of flail injuries and trauma upon landing. A little bit more about the future challenges. You can see here, we're going to start landing in water. We've been doing this with SpaceX vehicles. We're also going to do this with our upcoming Orion as we start to go to the lunar surface. We're going to start building the Gateway, which is going to be in a near rectilinear halo orbit around the moon. This is going to be a lot more time, probably about 5 days to get back to definitive care. It's going to be a much smaller, it's not the size of the space station, and it's going to be much more remote in terms of our cargo access. And then certainly going to Mars, once we start that trans-Mars injection burn, we are not coming home. We don't have that capability to turn the spacecraft around, most likely, depending on where we are in that burn series and come home. So we are now committed to being very, very far away from the planet. We're going to start to have 20-minute comm delays, and there's going to be a lot of things that we're thinking about that will significantly change our paradigm when we go to Mars. So this is where we are right now, Earth reliant. I've got our 6 to 12 month missions, and this is ours. It's 24 hours is a safe bet. We definitely can get back within 24 hours. We are still working on the basics of spaceflight medicine in these remote environments for long duration. As we go to the lunar surface, we're going to start expanding our capabilities. We are going to start traveling beyond this low Earth orbit. We're going to have the Gateway station, and then we're talking about possibly 1 to 12 month missions here. Our early lunar sortie missions will be 30 days or less, but we want to do some shakedown missions before we go to Mars. And so we'd like to be in deep space in our craft, probably orbiting the lunar surface for 12 months to see, you know, before you shoot this thing off to Mars, is it habitable for 12 months? What are the problems that crop up? And then at some point we'll be Earth independent. So these are these 2 to 3 year missions, multiple launches, you know, lots of challenges in terms of radiation, food, long distance from Earth. So our telemedicine on the way to Mars and on Mars is going to be quite the challenge. We'll have communication delays up to 20 minutes. So we can't do these private medical conferences where we've got near real-time conversation between the crew and the flight surgeon. It's going to be much more phased, where the crew will document what's going on, take all the imagery they can think of, give a video or a written log, send that to the flight surgeon. The flight surgeon will review and then send a response back in 20 minutes, suggest additional diagnostics, this kind of thing. So the crews are going to need to be a little bit more autonomous in their ability to do this kind of diagnosis and get the right information to the physician. We are never going to get out of the loop where we don't have a physician present. They are always going to be monitoring the astronaut health. But we will be a little bit less reliant on that real-time ground support. So instead of doing the remote guidance with somebody giving you feedback with a 1 or 2 second delay, we're going to have to move towards autonomous models, possibly AI machine learning, databases that can guide that crew member and how to do a good scan, and probably a lot more training on the ground. So that is the end of my presentation, and I hope you enjoyed our very quick tour through the history of telemedicine in space, and I'm definitely happy to take any questions that you may have.
Dr. Rubens, that was an amazing presentation, and I know that I could probably listen to you talk about the space and the space medicine and what you've gone through. I could probably go through that for days here, and I know there's going to be a lot of questions in the audience, but as excited like a kid over here. One of the things I wanted to ask you was about, recently I read an article that was published on the BBC that was talking about bacteria. They're finding maybe some new bacteria on the space station. And if you had anything, if you knew a little bit more about that, or could tell us anything interesting about how NASA's approaching that, like the idea that there may be bacteria that evolve differently in space or that grow differently in space.
Yeah, absolutely. I love this question because I am a microbiologist by training and have worked a lot on the genomics. And so if you think about the space station, this is a unique environmental niche. It has been separate from the Earth for 20 years. So yes, what's going on with that microbiome up there? A couple of factors influencing it is we probably have a lot less importation of microbes than you would see in a standard setting on Earth. We don't have vegetables that we're bringing up. We sterilize the food. There's no dirt. There's no pets. There's not a lot of ways to introduce microbes to the space station except for other germy human beings. So we do quarantine those guys. So we do see a very interesting kind of census on the space station, as you would expect. There's lots of staff. There's all these commensal skin bacteria, but we're also interested in things like diversity. As you have lower diversity of your species, then if you get a bad actor in there, there's a lot more environmental room for them to start growing. And so this is how we do this. We do this swabbing and we do this environmental monitoring to see, make sure we don't have any human pathogens or microbes of concern. What we're starting to do now more is actually use sequencing rather than just plating them and looking at a plate for identification, sequencing to come up with a census count. And we're still very early days in this. I just came back from the space station about a year ago and did an experiment where I took 800 swabs all over the space station to do full genomics and proteomics on it. And so we're still working through that data. So this is an evolving story. But one of the things that we have found and that we're interested in is new identified species. And I'm not going to call them novel species because my bet is these species existed on Earth and there's so many bacteria out there, we haven't sequenced every single one of them and put them in the database. But now that we're doing this very intense monitoring of the space station, we're picking up species that have not been identified. It is a very interesting question. Can we then go find these on Earth? My bet is we're not in the time scale to evolve a completely new bacterial species, but we could have some very interesting changes in the bacteria, particularly if you look at the 20-year course. So that's where we start wanting to do things like isolating bacteria and sequencing genomes, and particularly sequencing these genomes over time. The experiment that I really want to do that I haven't convinced anybody yet is to get a chemostat up there and look at yeast over 50 or 100 population generations, and to really do these experiments where we're growing microbes long term to see how they adapt to space. But right now,
if you'd like for me to help write that and
yes.
go up and be the first person to brew beer in space, that would
Absolutely.
be fine with me. I could.
Absolutely. So we definitely want to characterize what's going on with the human microbiome, and there's been efforts for the skin as well as the gut, and then to kind of increase the surveillance that we're doing in the environmental microbiome. Great question. Oh, and there's one online. Survive outside the ISS. Yes, this is also a super interesting point. Tad controversial. So the paper that was published, it was a Russian paper, and they had taken swabs out on an EVA and then swabbed the windows and around some air vents. However, they claimed that they found a plankton-like species on the exterior of the station. However, if you look at the video, the swabs were touching a lot of things, not just the surface that they swabbed. And I'm just to peer review it and be reviewer number 2, I'm not sure the right controls were included. You know, when you're talking about finding genomic bits at the sub-nanogram level, these really rare low mass nucleic acid species, if you don't check the water that's been in your reaction, the lab, you know, the technician, their gloves, you can pretty quickly introduce something into your sample and then think that you found it. So the kinds of controls that we want to implement, NASA is also doing this experiment now with controls to look at a swab tube that has never been opened. So if it's never been opened and exposed to that environment, it's a good negative control for anything in your processing pipeline. And then a swab that was opened and just kind of waved around in the vacuum of space and hasn't actually touched anything. And so I think those controls in replicates are absolutely critical to any claim of identifying a new species. And not to be super dogmatic about it, but I view any of the new species claims with some skepticism.
We did have a couple of questions from earlier that went into the chat, so I'll just pose them from the audience. So one question was about if you're able to do CPR in space, or what happens in that case, I guess.
Yeah, super interesting, right? Because on the ground, you're like relying on gravity for your compressions. So we have we essentially have a board to stabilize the patient, particularly for head trauma or any spinal issues. We have straps that go around the patient, 3 different areas of their body. So we essentially strap them to this board so they're not floating away in microgravity. And then the crew members flip upside down, put their feet on the ceiling and use that as the reacting force for their compressions. When we run a code on space station, we assume there's only one crew member traumatized. And so we have one doing the CPR, the others hooking up the AED, and the third, if we have that resource available, is prepping the medications. We have atropine available on board and is communicating with the flight surgeon on the ground, positioning the camera. And so we can actually do a pretty good job with this. We also practice it where, you know, maybe we only have a Soyuz crew, we only have 3 people. So we might have 2 Russians and Americans, and that team has to practice together to run that code and run that CPR. There's a few other ways of doing it. You can take one of the straps on that board and put it around yourself and work against the strap. But depending on the height, most people prefer to just flip upside down and do those compressions based on the ceiling, and then probably have a separate person doing the airway management. And we've got an ambu bag. We have the ability to intubate, but the question is, if you intubate, you can't really bring an intubated person home, so you're going to have to extubate at that some point, and we just don't have the kinds of, you know, we can intubate, but then we've got a bag. So we don't have the management that you would expect for an intubated patient. And so we only train the physicians to intubate. You know, we'd have to think about that case. It could be a very difficult one. So that's how we do CPR.
Well, you mentioned the AED, and I had a question about that AED. To me, in my mind, because I did a lot of engineering background, I think, okay, well, you do the AED and it discharges to someone here on Earth. It's just going to go to the ground. But you're in a metal tube, and there's a lot of really sensitive. So do you guys have special, precautions when you do the AED to make sure that they're not grounding into your flight computer? And
yes, so the AED is normal. We haven't made any modifications to that. But this board that we're isolating the patient on, that is electrically separate from any metal on the space station. And so we do have to be incredibly careful that nothing contacts the patient. Certainly we're always worried about a human getting in the way. We really work on the communication there. And it's a little bit, somebody says clear on the ground and everybody can take a step back. In space, if you're floating, you have a little less bodily control. So we definitely watch that area and clear before delivering shocks. And then we want to make sure none of the comm equipment, none of the computer cords are anywhere near that. So we actually conduct audits about on a monthly basis to make sure that space is clear, set up, ready to receive a patient anytime, and that there's no electrical hazard.
Dr. Rubens, this is a very interesting topic. Thank you very much for gracing us, with your presence here in TechSLA TRC webinar. I am very interested with the trauma. I'm dreading operating on patients who is anticoagulated, and it seems like all the astronauts are, based on the data you presented. And also, I'm kind of thinking of, hydration and resuscitation, blood products and whatnot. You would do that in space. And do you have the same dosing of medications as well? Because I'm pretty sure there will be some effect on, on the weightlessness and whatnot.
Yeah, great questions, all of them. So in terms of the coagulation issues, we think there may be some disrupted coagulation in all astronauts on board. We haven't run that down. So we don't really know the coagulation status on board. The thrombus issue has only been one patient so far. So we may have this more in the future. We're starting to really heavily screen people on the ground now for any physical evidence, as well as making sure we are looking at their coagulation cascade. So not everybody is on these blood thinners, but it could happen. In terms of the hydration, we are well hydrated for our microgravity environment, but certainly with trauma, you'd add that IV on, and we do have IV fluid that we send up, and we are all trained in how to insert an IV catheter. And so I think we would manage that fairly closely to what we would do on the ground. We do have weights for these patients, and we would probably make some adjustment for the altered volume of fluid, but there wouldn't be an issue with pushing fluids right away. And then the medication question is a very interesting one. We have a whole area of research on this because we don't know, are the pharmacokinetics altered by microgravity? One concern is these medications may be on board for several years, and they're also exposed to the radiation and microgravity environment. Do we have degradation of our medications? And so we're doing a very interesting study where when our medication packs expire, we actually send those back down to the ground, and we're doing potency testing on those. We don't have all the results yet, but we do want to learn about differences in just the physical aspects of these pharmaceuticals in the space environment. In terms of the patient response, yeah, I would guess there's going to be some differences. We've got all of these changes, but we just don't have the capacity to do the studies. So we're dosing like we would on Earth. If there's milligrams per kilograms, we do take into account the weight in space, which we actually measure using F equals ma. We sit on a little spring and measure the acceleration force as it pushes us out of the wall, and then we can calculate our on-orbit mass, which is oftentimes lower than our Earth mass. But we just dose based on that space mass. Great questions.
Another benefit to going to space is you lose weight, guys. So you lose mass, but
I had another question that came in through our telehealth interest group, student interest group here. And that is, what are the current issues that NASA is exploring concerning telehealth technology? I know you touched on it, but if you could expand, that'd be great.
Yes, so we're thinking a lot about how to expand our capabilities on board. There's a faction that would like to see lumbar punctures in flight. That scares me a tad. There's definitely people that are looking at really increased use of molecular diagnostics. I think we're going to get a lot of bang for our buck there. We're waiting for the science to catch up. We would like more molecular diagnostics for primary care to be available rather than just, like cancer genomics. But we have all of that set up. We're always looking at different imaging capabilities. I think we're pretty happy with our OCT and our ultrasound right now, but we're looking at things like the butterfly portable ultrasound. Could we do, more time points, maybe as the crew is launching or landing? Could we take ultrasound in the field immediately after they've landed? And then certainly it's a huge issue going to Mars. So think about all the suite of equipment that we're going to need. There's a big effort to look at the computational infrastructure that's going to surround that. These AI models that we've talked about, how are we going to use advances in non-human predictive capability to help get over our comm issues. That would not ever replace the flight surgeon, but it might give you a more immediate answer. And then everybody always talks about surgery on the way to Mars. I think it's questionable. I think it's laparoscopic only. There's a lot of stuff floating around. You got somebody who doesn't know how to maintain a sterile field. I don't know. We'll see. There's lots of puts and takes there and a fair amount of risk, but it's certainly something that we're looking into. I've done, mouse surgery and mouse survival surgery on board, but we haven't put anything in a human yet.
Yeah, that's where a lot of stuff starts though, right?
Yeah.
Got another question in our chat there, and it says, in terms of space adaptation, what type of protocols are there for regular exercise or therapies for the astronauts in the ISS?
Yeah, so for the space adaptation, sickness, it's just like, don't move around, don't move your head, don't do flips, even though you're excited you got to space, like wait for a week. For our general adaptation, we're most concerned about muscle loss and bone loss. And so our countermeasure there is very heavy loading through extreme resistance and focusing on eccentric contractions. And so when we first started flying, we were on these exercise bands to, have some force to work against, but they don't load in the same way, and you can't get that load very high. So we've developed a device called ARED, Advanced Resistive Exercise Device, and that has cylinders of vacuum that can go up to 600 pounds of force and a bar, like a squat rack that you would see. And so we do a lot of squats and deadlifts and then all the accessory exercises to load up your bones. We exercise for 2.5 hours a day, and 1 hour at least is devoted to strength exercises. We do sets of 10 to 4, and you don't have to account for your body weight doing squats on board, so you can actually lift a lot. So I was able to squat 300 pounds. I thought that was really cool. I'm never going to be in a 300-pound club again, but we intensively train that lifting. That has reduced our incidence of bone loss down to almost 0. We still have muscle loss. We also have cardiovascular training. We've got a cycle ergometer with no seat. You just pedal as you're floating. We have a treadmill where we bungee ourselves to the treadmill with a particular amount of force, and then can do sprint exercises. So we use all of these. We're struggling the most now with back pain upon landing and degradation of the paraspinal muscles. So they're just losing their muscle tone and capability. When they come back, and then also you load them with an actual human weight, they just seize up and you get a lot of back pain that disappears after about a month. But we're seeing this a lot in people. We used to think this was related to the intervertebral space between the discs and compression and then relaxation of that, or maybe that spinal curve. But we're now thinking this is a lot more due to lack of exercising these tiny little stabilization muscles, and then you sure need them when you get back into microgravity. So we're looking at ways that we can load those up. We've focused on the big lifts. We want our quads and hamstrings to be exerting force on that bone, but now we're thinking about the smaller postural muscles as well.
All right, we've got a couple more questions coming in. So the next one is, what do you think is the next disruptive innovation related to space flight and adoption to virtual care back on Earth?
So I think for us in space flight, computer-based modeling. So starting to put more of our data into a model, digital human type model, starting to figure out how the astronaut, the flight surgeon is interacting with this computational system. How predictive can we be with this? How we can do in terms of having just a computational system inform the first 20 minutes of a response. How much can we train the person a little bit and get into the system, or do they need a lot of training because our models aren't that great, our guidance is not that great? I think you can get it pretty good. I mean, I think as a professional scientist, non-medically trained person, with a nice diagnostic workflow and some specific prompts, we could do a lot with that. So I think that's really where we're going. Of course, the farther future, everybody loves saying AI, but there's some really interesting things we can learn as we increase our computational power and also our predictive and surveillance power. So I think it's a big groundbreaking one in space. It's probably pretty similar for telemedicine on Earth.
Right, we've got another one. Is NASA committed to continue this very excellent research in the future mission?
Absolutely. So the space station is right now is certified to 2030, and we're still having discussions among the international partners, but the U.S. intends to fly this to 2030, and so we're going to add to our research capabilities certainly. And we are committed to this for long duration missions. It's absolutely essential. You know, NASA is never going to send a one-way mission to Mars. We value human life, and we're going to make sure that we can have really good care of these humans. It may not be everything you could get on Earth, but we're going to come as close as we possibly can.
Awesome. And when is your next space mission?
So I just landed. I've done 2 missions total, and so we usually take a few years off because the training for a mission is 2.5 years, and then 6 months of flying. I'm on the short list. There's a kind of an Artemis crew for lunar exploration. So I'm part of that, and I'm spending a lot of my time working on new spacesuit development, the physiology of the human in the spacesuit, and how we are going to return to a dusty 1.6G environment in spacesuits and conduct spacewalks there. So lots of interesting physiology and monitoring. We're very concerned about lunar dust. I spend a lot of time talking about spacesuits and lunar dust, and hopefully that will play a part in the next mission that I fly.
And I have to ask this question because I'm a bit of a sci-fi nerd as well, and one of my favorite shows, they talk about how difficult it is to stop bleeding in microgravity or zero gravity. And, you know, the show is supposed to have great cred for hard science. And I always wonder, do you guys go through any sort of training that talks about that when you're, you know, trying to stop bleeding in microgravity? Is that a different environment?
Yeah, I mean, we haven't done a lot of research, and we probably could do some animal model research on this. There's some kind of anecdotal indications that wound healing is slower. In terms of immediate bleeding response, you know, it depends on the extent of our coagulation dysfunction, which I think is pretty mild. I think the problem is less like how much are you bleeding and how quickly are you clotting, as to the blood's going to behave really differently. It's going to go places. So when you get fluid on board, it's got this surface tension or these forces of adhesion, and it's whatever it sticks to, it wants to go along that and it wants to spread out along that. So if you have bleeding, it's probably going to go in some different places. It's going to be very adherent to the skin. You know, in terms of internal bleeding, it may be, that's probably a little bit closer on the ground because you've got all the stuff all around you, but you don't have gravity forces. So you're not going to be, you know, if the patient's in a certain direction, you can't predict that blood is going to accumulate in any particular place. It's going to spread out along surfaces, and anytime you deal with fluids on board, it goes into places you would not expect. So our management is pretty much the same as it is on the ground, but we would expect possibly some complications.
Well, I would like to thank you. I don't see more questions. I'm surprised everyone's being shy because I could sit and talk to you like all day long. It would be great. We probably have a lot of interesting things to come up with and really talk about this. So we're so very glad that you were able to come and present, even though we're a little hectic with your travel schedule. It was an excellent presentation. We are all so much wiser for it. We are looking forward to the great work that you and the rest of NASA is doing. And we know that a lot of what we do in our regular telemedicine is built on the work that's been done at NASA before, you know, and some of the work that you guys are doing now to help lead us into that next level of telemedicine. And we really appreciate that very much that you're able to be here for this. You know, thank you. And let us know if there's anything you need from us, because we would love to have you back for any other sessions.
Absolutely. I love what you're doing. It's so important. You know, I mentioned I worked in Congo. We had some very, very remote field medicine at our monkeypox clinic in central Congo. And so that's what first brought my attention to the possibilities for telemedicine. It's definitely useful in space, and you're all doing incredible work on Earth to reach patient populations we normally wouldn't be able to provide this level of care to. So thank you.